one session. And I myself was of the opinion that we can do a two assist transfer where the assessor assists the patient from the shoulder joint, from the shoulder area, while I do the swing using the limbs. So, which one do you really recommend, especially if the patient has got a few attachments?
Yes. So what I would do first of all, while the patient is lying down, try to get all the attachments to one side, any side, But what I would do is, if there is intercostal drainage, then please go to the bring to the side of the intercostal drainage, because it's painful for the person to when the intercostal drainage is in the other side. But there have been scenarios where there are two intercostal drainages, one on each side. Then you have to choose one side. Usually choose the side which is more, easier to the access to the door, or maybe But then rolling. When rolling, the question would be rolling only. My only worry with the rolling would be if there is an intercostal drainage on the left and you roll the person to the left, then it will be painful. So just be mindful of that. Maybe do a semi-quarter turn and then help him.
Somala, I'm sorry for interruption, but
No, that's okay.
I know Michael is talking about a case that we already practiced together, me and him. So this case has intercostal on one side, right? And my point of view is to roll him to the other side, and then use the bed mechanics to sit him up, all right? And me as a therapist should be the back side to help him and to make sure that the intercostal tube is safe, not to be blocked or stretched, all right? And the examiner will be my assist to help with the legs, because he may be in another case of the fracture where the patella is fractured and there's a Zimmer splint as well. So I mean, like, I can use rolling to one side and the bed mechanics to set the patient up, with the examiner assisting me from the legs.
Yes, you could do that. Yeah. So yeah, I think by what you explained, I feel like you could do that as well. So what is the disagreement on exactly?
Because Michael, he thought that his way is better, which is to assist one through the legs, one through the chest or the back of the shoulders, and we pivot the patient from supine to sit at the edge of the bed.
Yes. All right. So that I would say, if this client has intercostal drainage, and then you need to bring the client on the side of the intercostal drainage itself, better to pivot. I like that technique, because I'm avoiding.
Sorry, can you repeat that again, please?
If your patient has intercostal drainage on the left side and you need to bring the person out of the left side, then when you roll the person on the left side, you will press on the intercostal drainage. You put pressure on it. That's why I would avoid rolling. But for that client, instead, I would do the technique that you just did.
But rolling was to the other side, to the right side.
If it's to the other side, I do not worry, as long as your intercostal drainage, the chamber, the container, you have brought to the right side, to the side where you are bringing him to, then it's fine. And as long as because if you roll him and your intercostal drainage chamber is still on the other side, you will tug at it, and then it may disconnect that. Then that's a worry. Yeah. And the other thing is, like, rolling, I would use for my patient with abdominal surgeries, because abdominal surgery, you should not put any exertion on the abdominal muscles. So rolling is very safe technique. Like, you roll onto the side, then push on your elbow and come up. So that is very safe technique to do for them. Whereas for others, it's fine to do that pivot technique, or like coming up the bed and twisting out of the bed. That's fine. Yeah. I hope that I made that clear.
Yes. Thank you.
Thank you.
Thank you.
Any other questions, please?
Sumana, I want to ask, so if a patient has a catheter, is there, like, how we can hold the catheter if we want to mobilize the patient? Can we just give the, to the patient, or we have to hold the catheter? Urine catheter.
You can do both depending on how your client is and how many attachments you have. Like if your client is not too tired or not too uncomfortable, then you can ask him, can you hold this catheter? Are you comfortable to do that? If not, then you may have to hold that for him. Yeah,
Okay,
so
but there is,
how the client presents.
yeah, so there is nothing that can attach the catheter to the patient's leg.
No, there is nothing like so far, nothing like that.
Okay.
I think someone wearing a surgical gown, and then it had pockets at the end, at the bottom, so they hung it on the pocket. But just be mindful if you do that, like, it's a hindrance again for that person when walking. He's hitting that when he's walking. So I don't know how good is it to do that. I would hang it only on the walker. It's comfortable when you hang it on the walker. There is no issues at all. But hanging on the dress itself, I find it quite uncomfortable for the client. So I would be just mindful of that. You can ask him to hold. I think it's okay to ask him to hold it.
Okay.
Yeah.
And in chest expansion, do we need to do just thoracic, or we have to do apical as well?
Oh, depends. Or this again depends on what you see in the client. Apical. What do you mean by apical? Do you mean to teach apical breathing technique or stop them from doing more of apical breathing technique?
I mean, just in the assessment to see if they, if there is, you can.
Yes, in the assessment, yes, please. Yes, that's a good point. I think, yep, I should have talked about that. That's a good point. I would like check what's the breathing pattern, apical versus lower chest. Like some may be doing more apical breathing, upper chest. So then you can say, I'm noticing there is more of upper chest breathing. And they do that. Actors will do that. I have had many of my, say report that they were doing like very good upper chest breathing. They were observing, but just give a prompt to the actor, because they're actors. They don't constantly do that. So when you say, I'm now going to look at your breathing pattern, and then they will start doing that. Yeah.
Okay. And one more thing. So when should we check the cuff strength? Is there any particular point, like before auscultation we have to do, or we can check at any point?
You can check it.
Cuff strength.
Yeah, don't do it. Of course, better to do it before auscultation if you ask the rationale. Because if you ask someone to cough, then that changes their breathing sounds. So breath sounds, if you do before and then do the cough strength, is good. But let's say you forgot it and like you remember at some other point, it's all right as long as you do it. And because it's important to check that. That's one of the things they would look at if someone has a. Yeah.
Great. Sumana, I have one question, but it's just not, it's about the hypothesis. Not hypothesis. When we're introducing ourselves to the patient, do we say that this is an exam scenario? Do we say this line to the patient?
Yeah, I would say that. Yeah, I would say that. Yeah. Yeah, that's fine to say. Or not.
But if we don't say, does it matter?
Yeah, that's fine. As long as you have introduced yourself as a physiotherapist and have introduced the examiners as being just observant and asked his consent of them being present. That's all. That's all.
So like usually what we do is, so for example, if I'm introducing, I'll say, okay, hi, my name is Kavita. I'm your treating physiotherapist today. This is these are my examiners. Do I introduce them saying that these are my examiners, Mr. A or Mr. B?
Yes, yes.
Okay.
I mean, if you can remember their name, good to give.
Yeah.
But I forgot their name. So I just say, these are my examiners. That's all.
Okay. Yeah.
Usually they will be like, yes, sure, fine. It's just they need to see you take consent from them, from the client. Okay. Is happy with some third person being there.
Yeah. Thank you.
Okay. Right. So treatment expect, I knew today that I will run out of time to go into detail with the treatment expects, although I have quite a bit here. So I'll just go briefly through this because my focus was more on like assessment criteria and making sure we set a proper goal. And once you have set a proper goal, then comes the treatment part. And usually these four are our treatment areas that we can work on, like improving the lung functions, managing the symptoms, improving the exercise capacity, or managing other symptoms. And all these things we can do as short-term goal as well right away there in the exam, because managing symptoms like cough, symptoms of breathlessness, symptoms of pain, you can manage it right away, bring improvement. Lung function, you can bring improvement in the chest expansion, you can bring improvement in the breathing pattern, you can bring improvement in auscultation sound. So these are all short term that you can show right away. Exercise capacity, don't be scared with that word exercise capacity. Like most of the time, like many will say like we can't really do anything there, but just getting the person out of bed, get him out of that room, that's it, you have already improved his exercise capacity. So when talking to the patient, say like we can work on improving your endurance, improving your exercise capacity to getting you out of the bed. Have you walked up to the door? Right. How about we try walking out of the door? Like maybe 5 meters out of the door. So set it up right like that. They really like that objective goal setting, so that you can show that it's done as well. And then other impairments, there could be like anything around like someone has urine incontinence with coughing, managing that, giving them technique about like holding or Kegels or something like that. Any other symptoms, like that lady with the Zimmerny splint and the fracture of the patella, you have to make sure you also give a little bit of, isometrics for the quads. Tell her about like being careful of not bending the knee, because that actor was a very careless one, and she would like try to move her knee vigorously. So protection around that, things like that. There could be other impairments. Right. Now, as we move on to managing the symptoms, managing breathlessness and managing pain are two things. For managing breathlessness, breathing control. With breathing control, I think someone asked this earlier. For managing breathlessness, you have options of teaching pursed breathing, relaxed breathing, like relaxation techniques. As you were saying, you can just, if someone is really anxious, like my client was very anxious, had to ask him to lie back, rest, relax, lean back, close their eye, and like really do the visualization technique where you ask him to think about something that would calm him down, some place that he really likes to be, and so that he feels a bit more relaxed. And you can do that, or relax breathing with counting like 1, 2, 3, and like when I say 1, breathe in, when I say 2, breathe out. So they are really calming themselves down. Pacing is the technique where you then use counts to do the activity. When with the count of 1, put something on, count 2, breathe in. So something like that. I'm not going to detail today because I'm running out of time. But then others are positioning technique. I'm sure you all know all the forward leaning techniques that you can use to relieve breathlessness. Managing pain, splinting technique, and when managing pain, like please monitor the SpO2 as well, because of pain, sometimes they don't breathe properly and the SpO2 drops. So monitoring their SpO2 throughout is important, especially for someone with breathlessness. Really important to monitor the SpO2, and the SpO2 itself, the saturation level, could also be your outcome measure. If someone is at, let's say, someone is at 90 or 95 in the beginning, does a little bit of walk, goes down to 86, you let him rest, give him some breathlessness management techniques, give him some break. Again, the SpO2 comes back to 95. That means you have done one outcome measure there right away. So you're managing outcome there. You are showing your outcome measure there as well. These are the, again, breathing control, pursed lip, and pacing technique. I won't go in detail here. Dyspnea relieving positions here. How to manage the pain through splinting over here. So some of the splinting techniques. You can use them with chronic cough pain, or you can use it with someone with abdominal surgeries, as you see here. Then next one is improving the lung function. With this, you would look at improving the lung function, that you would know. So you need to work on that if someone is not doing good deep breathing, really shallow breathing, really bad auscultation sound, like reduced breath sounds everywhere, or if there is someone with lots of cough and airway clear is not clear as well, they also do need to improve their breathing and lung ventilation. Or someone with when you look at the chest expansion, just by observing, you can see that would be someone. And or even someone with like SpO2 level is reduced, then you can also work on that as well. So you improving the ventilation. There are positioning techniques again, and deep breathing exercises, incentive spirometer, and thoracic expansion. So thoracic expansion exercises like lateral basal expansion is quite enough. Doing just one is enough, or just the diaphragmatic breathing, where these are few of the techniques. The positions. So always, like, positioning is like just educating the client, saying like sitting is upright is always better than being lying down. So our standing and walking is always better than lying down, because your lungs will expand better. So always aim at, it's always good to, if your client, patient in cardiorespiratory, if they are lying down at the beginning of your assessment, if by the end you are able to bring them to sitting position, whether it is in the bed itself or in the chair, it's good. You have achieved one outcome, because he was lying down, his ventilation was bad, you brought him to a better position. So you have given one outcome there as well. So there are so many opportunities and ways to get your outcome. So, there are plenty to work on. And if you just show at least 2 or 3, that's enough. Then you can work on deep breathing, diaphragmatic breathing, and lateral basal expansion exercises. You may give incentive spirometer as well. If they already have an incentive spirometer there, some will have it on the bedside. Some scenarios, they have it already on the bedside. In the lab, they have both of this. They may give you any of this, or you may choose to use any of this. And you can always explain to them like how incentive spirometer is good for them, because it opens the collateral channels and opens up all the alveoli. So you can give patient education there. The next is sputum clearance or airway clearance technique. So the huffing techniques. For huffing technique, if you go into, I will send you the link of this video. Oops, I was going to play a video here, but I can send you the link of that video. It's a really good video of how to do a good huffing. It's from one of the websites in Australia. So I'll send you the link now in a bit. You can teach that. Other techniques are like directed coughing. As I said earlier, if someone doesn't do a good cough, like effective cough, because they're scared or inhibited by pain, then you can tell them these 4 phases. Tell them like these are 4 phases of, 4 phases of coughing and how to do each phase. So there is technique on teaching them each phase, but I can't go into the detail today. However, just showing you that you can also give directed coughing here. And then, of course, ACBT, which everyone really does practice commonly. So doing this ACBT cycle of breathing control, a thoracic expansion, and forced expiratory technique. Then one of the other lung function improvement options is walking. Like many times we forget that, but getting someone to walk itself is also improving their lung function. So use that as your, one of your treatment measures. Keep saying, look, if you are able to walk, you're going to expand your lungs, your diaphragm will work better, your lungs, you will fill with air better. So if you get them walking, let's say your client does nothing at all, at least if you got the person walking more distance than before, you have done it. You have improved their lung function. You have improved their airway clearance. You have improved their endurance, exercise capacity. So you are good. So don't panic if you can't do specific respiratory techniques on your client. If nothing works, please get them to walk a bit further, or at least get out of the bed, or get sitting on the edge of the bed, something like that. Then the other options you still have is using the positive expiratory pressure devices. All these devices are in the lab, so I have put it here. You have a flutter there, you have this green Acapella, and this one. There is a very similar looking device like this. bubble pep. You can use any of these if you like, especially for airway clearance. Some of them will have this with them already. I think none of the scenarios they have already, have a client already using them, but you can choose to use them if you are comfortable with using it. Then improving the exercise capacity is also about, like, as I said, like walking is important, but sometimes because of breathlessness, they try to avoid that activity. You will find they will be like trying to avoid activity, scared because they will get tired, or scared because they will get breathless. So tell them about this cycle. I like this cycle a lot. I always tell my clients, if you get breathless, you will do activities, you will not do the activity because you'll get breathless, and then you will do less, and then you become weaker, your lungs will become weaker, and then you'll get more breathless. So I use this to explain and educate why it's important to walk. Many of the scenarios I have found, they will not walk for you. They will be like, I'm not walking. And then when you do this one, when you do this education, they are walking right away, because the actor are given this script. They are told, if you explain what's the reason for walking, why it's important, then they will walk. So please remember to educate the client when they want to take them for a walk. Then you can also explain. You of course cannot do this in the exam, but you can talk to them about pulmonary rehabilitation model, and when you are referring them further, so you can talk about aerobic exercise, strength training, spinal mobility. These are the things that include in pulmonary rehab, and how it works, and how you can refer further. Yeah, so that's all we have. I went very quickly through this. I'm sorry, but I had planned it that way. I knew that the assessment part will take a big chunk. So if you all are interested, I can go through all the treatment part in detail with like how to explain, or deliver this to each client, and how to rationalize doing each of these techniques as well. But it has to be next time because we are running. We couldn't be within this session. Sorry about that. Do you want? Is there any questions, please, or any feedback? So that's all I have for today.
Thank you so much, Savannah. Thank you.
Thank you.